Good evening, everyone. Welcome to the start of the Diabetes Update webinar series. Today's webinar is on diabetes and chronic kidney failure and is brought to you by the Physician Learning Program and the Office of Lifelong Learning. I'm Dr. Roshan Abraham, a family physician and an assistant professor in the Department of Family Medicine in the Faculty of Medicine and Dentistry. The Office of Lifelong Learning is committed to providing the latest information, advice, and resources to support continued educational needs of healthcare professionals and their teams. Just before we begin tonight, I would like to go over some housekeeping slides. We acknowledge that we are on traditional territory across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. I am pleased to introduce our three speakers for tonight. Dr. Rose Yeung is a clinical endocrinologist and an associate professor in the Department of Medicine at the University of Alberta, Canada. Her research interests include diabetes, quality improvement in healthcare, and implementation science. She is a medical director for the Office of Lifelong Learning at the University of Alberta. Dr. Yeung is passionate about patient education and empowerment, co-founding the Edmonton Zone Diabetes Resource Review Committee, board member of the Type 1 Diabetes Think Tank Network, a consortium that brings together patients and healthcare providers to break down communication barriers and inform more humanistic practice. And she's the co-creator of the educational website, diabetespregnancy.ca. She values broad community engagement and was the 2018-2019 chair for the Edmonton Area Professional Section of Diabetes Canada and is a core committee member of the Alberta Diabetes, Obesity, and Nutrition Strategic Clinical Network. Our next speaker, Dr. Darren Lau, is an academic general internist and diabetologist at K Edmonton Clinic. He completed a PhD in clinical epidemiology in 2012 and his general internal medicine residency in 2019, both at the University of Alberta. He attends clinical teaching units at the University of Alberta Hospital and has a modest outpatient practice consisting mostly of people with complicated diabetes. In his research life, Dr. Lau uses administrative databases to develop insights about the outcomes of medical care in people with diabetes. And of course, Dr. Donna Manca. She is a family physician, a professor, and the director of the research program in the Department of Family Medicine at the University of Alberta. She is the director of the Northern Alberta Primary Care Research Network, a network contributing data to the Canadian Primary Care Research Network. NAPCRN, so it's called, extracts information from electronic medical records, cleans and structures the information for the purpose of quality improvement, surveillance, and research. Dr. Manca's research interests include primary care, implementation science, privacy, ethics, research networks, cancer and chronic disease prevention, screening, and management. She is a Diabetes Action Canada investigator contributing to the National Diabetes Repository. She is also a medical director of the Physician Learning Program and the medical director of the Better Training Institute, aimed to improve chronic disease prevention and screening across Canada. I turn it over to you, Rose, to get us started.
Thanks, and I'm going to turn it over to Darren to get us started.
All right. Thank you, Dr. Abraham, for the introduction. As he mentioned, I'm a general internal medicine physician at the University of Alberta, and I'm grateful for the opportunity to talk to you today. I'm so grateful I put a tie on, and it only took me 4 tries to get it right, because I haven't done this in a very long time. But there you go. This tie is for you guys. Anyways, okay, so today's topic, we want to talk to you about new things you might do for your patients with diabetic kidney disease. So here are the objectives of the evening. Thing number 1, we're going to talk about GLP-2 inhibitors. These are newer agents with cardiorenal benefits, and we're going to describe how they work. Thing number 2, we're going to sketch the evidence for the renal benefits of these agents, and you're going to find out why the kidney doctors are so excited about them. Thing number 3, we're going to apply these agents to a case, a hypothetical patient, which I hope you'll recognize in many of your own patients that you see every day in practice. And finally, it's our hope that at the end of this talk, you'll take a moment and contemplate and think maybe about how you might ensure that all the patients in your practice who qualify for these agents benefit from them. And Dr. Manca has some quality improvement or some practice management tools that you might find specifically interesting. Okay, Rose, I'll take the next slide. Oh, Let's cue up my notes. All right. So this is our motivating case, Mr. Darrell. He's a 62-year-old male with diabetes. He's had diabetes for a long time. He's actually put a fair bit of effort into improving it over the last 2 to 3 years. And so his HbA1c in your clinic is 7.1%. He has a bit of hypertension as well. So he's on perindopril, metformin, and gliclazide, and he is a smoker. You measure his blood pressure, you examine him clinically. His biometrics are provided for you here. His blood pressure is 146 on 92. BMI is 31.2. You do your routine diabetes labs and you get an A1C of 7.1%. His urine albumin creatinine ratio is elevated, so he has macroalbuminuria for sure. His creatinine is elevated as well, it's 118. This is stable from where it was 6 months ago. And his eGFR is 54, so he has stage 3A chronic kidney disease. Okay, I'll take the next slide. So, all right, would you adjust his diabetes medications? Does he need additional glucose lowering? And is gliclazide the best agent for him? And what else do we need to talk about to optimize care? Now, if you think the answer to this question depends on how committed we are to Diabetes Canada's target A1C of less than or equal to 7.0%, I'm going to pause you there, because the real question for this particular patient is not about glucose lowering. Sure, we could chase that 0.1%, and I would, but the more important question is what can we do about his diabetes to improve his end organ prognosis? Because for the first time in a long time, we have medications for diabetes that actually benefit the kidneys and the heart. So today we're going to be focusing on SGLT2 inhibitors. Oh, was there a slide missing? Would you adjust, how comfortable are you starting SGLT2 inhibitors in chronic disease, in chronic kidney disease? And how many people in your practice do you think fit his profile? We're going to be focusing on SGLT2 inhibitors today. And while you think about all the questions I've put to you now, I'm going to let Rose talk about SGLT2 inhibitors and how they work.
Thanks, Darren. So the first thing we're going to talk about is how they work when it comes to the sugar part of the equation. So as many of you are well aware, the sodium glucose cotransporter 2 is found in the proximal tubules of the kidney and reabsorbs about 90% of the filtered glucose. And by inhibiting these cotransporters, glucose is then excreted in the urine to the order of about 50 to 80 grams of glucose a day. So to put that in perspective, a can of soda pop is generally about 40 grams of glucose a day. So about 1 to 2 cans of pop out of the urine a day. This mechanism is not insulin dependent or insulin sensitive, so it can be used in patients with different stages of diabetes with functional or impaired beta cells. But the degree of glucose excretion is dependent on kidney function. So if the kidney function isn't very good, less glucose will be excreted through this mechanism. And I just like this cartoon because what we're doing is there, in typical uncontrolled diabetes, there is a lot of glucose excretion in the kidney, and we're taking that usually negative effect and we're making it a therapeutic target. So the other part of the equation is the salt or the sodium handling that occurs with these medications. And this is really the interesting portion when it comes to the kidneys and how the sodium handling affects the renal hemodynamics. So in experimental models of untreated diabetes, proximal tubular sodium reabsorption is increased, and there is less sodium delivered to the distal portions of the nephron. And this is interpreted as less plasma volume. And so what happens is the juxtaglomerular apparatus transmits this signal, and we have afferent arterial dilatation, which increases the pressure on the glomerulus and leads to a state of hyperfiltration. And what happens is by using these drugs, we reverse this process. where we then allow the sodium to reach the distal nephron and be excreted, and then reducing the dilatation here to then reduce the pressure on the glomerulus. This actually has been shown to reduce tubular inflammation and fibrosis in animal models, having some kidney protective effects.
Thank you, Rose. Now, I'm going to talk a little bit about some of the clinical evidence for SGLT2 inhibitors, and I want to start with this slide here. You might recognize this slide. This is the Kaplan-Meier curve for some of the outcomes from EMPA-REG outcomes. And this was, of course, the cardiovascular outcome trial of empagliflozin versus placebo. And when this trial first came out, this separation of the Kaplan-Meier curves showing a cardiovascular benefit of empagliflozin was astounding. It was so astounding, in fact, that many people didn't believe it. It had to be due to bias. There was no way that this medicine could act on atherosclerosis so quickly. Well, it turns out it's a class effect, and it actually makes complete sense now that we know more about the mechanism of action of SGLT2 inhibitors, because SGLT2 inhibitors have these hemodynamic effects and other mechanisms of action that benefit the heart and the kidneys, for example, reducing salt retention, quite apart from blood sugar lowering. So the mechanism benefit is not just blood sugar lowering and eventual benefit for atherosclerosis. It's multifactorial with many other mechanisms that might not yet even be identified. So I'll take the next slide. I just have to queue up to my own notes here. There we go. So speaking of cardiovascular outcome trials, of course, the cardiovascular outcome trials of the SGLT2 inhibitors would be EMPA-REG outcomes for empagliflozin. We have the CANVAS program for canagliflozin, and we have declared TIMI 58 for dapagliflozin. These are cardiovascular trials, of course, and the primary endpoint is some variation of a 3-point major adverse cardiovascular event composite. But the secondary analyses of these trials did look at kidney outcomes. And one of the first signals they picked up was that patients prescribed an SGLT2 inhibitor had a lower incidence of progression to macroalbuminuria, a significantly lower incidence of progression to macroalbuminuria. Now, albuminuria, of course, we think it's a good thing to reduce it because it reduces ESRD when we reduce albuminuria. But albuminuria at the end of the day is a surrogate outcome, it's an intermediate. And so what the kidney doctors really care about are the hard nephrologic outcomes. And a hard nephrologic outcome is a doubling of serum creatinine, or equivalently, a GFR that falls by half in a sustained fashion, end-stage renal disease, or need for dialysis, or a renal death. And those three things comprise the composite 3-point hard nephrologic outcome that powers many nephrologic specific trials, many kidney specific trials. I'll take the next slide. And if you look at the nephrologic outcome, the hard outcome, as a secondary analysis of these cardiovascular outcome trials, again, there was a huge relative risk reduction. So this is a meta-analysis, and Rose is circling them for us here. These are the SGLT2 inhibitor cardiovascular trials. And you can see that pooled risk ratio, that pooled hazard ratio is 0.55, again, for hard kidney benefit, not just macroalbuminuria reduction. You'll note that GLP-1 receptor agonists don't have nearly the demonstrated benefit in hard nephrologic outcomes as SGLT2 inhibitors do, which is why today's talk is mostly focused on SGLT2 inhibitors, but you'll hear more about GLP-1 receptor agonists at our next talk on cardiovascular disease, so stay tuned. Okay, I'll take the next slide. Now, of course, these are secondary analyses of cardiovascular trials. You really do need a kidney trial to confirm this, and the first of its kind was the Credence trial. This was a trial of canagliflozin 100 milligrams versus placebo in patients with diabetes. And the inclusion criteria, you had to have CKD by eGFR, and you had to have at least macroalbuminuria. And so all of these patients ended up being pretty high risk from nephrologic perspective. If you look at the CKD and albuminuria heat map there, they all fall essentially into the red zone. And their HbA1cs could be from 6.5% to 12.0% for study inclusion. I'll take the next slide. Credence found that over 2.6 years, patients in the canagliflozin arm had a lower risk of the 3-point nephrologic hard composite, as well as CV death, all mashed together in a single primary outcome. And that relative risk reduction was about 30%, for a number needed to treat of 25. In preventive terms, that's a pretty spectacular number needed to treat. You had to treat 25 patients, but if you did that, you'd prevent either one sustained lowering of eGFR, or one case of requiring renal dialysis, or even a cardiorenal death. So pretty impressive results from Credence. Next slide. This is DAPA-CKD. This was a trial of dapagliflozin 10 milligrams versus placebo. And again, very similar inclusion criteria in terms of requiring CKD, so high-risk nephrologic patients. The big thing about DAPA-CKD was this trial involved many patients who didn't even have diabetes. So this was properly a CKD trial, and patients could have CKD without diabetes, maybe from other causes. And in fact, what they discovered was, regardless of the cause of CKD, dapagliflozin had a similar degree of benefit, again, on hard nephrologic outcomes, as well as that primary composite, a cardiorenal composite, had the same degree of benefit, which was quite remarkable. Next slide. This is just a bit of an aside, but a little bit more about DAPA-CKD. As I had mentioned, there are many other causes of CKD involved in, the patients have many other causes of CKD. For example, 270 patients in DAPA-CKD actually had IgA nephropathy. And as it turns out, that makes DAPA-CKD one of the largest, if not the largest, trial of IgA nephropathy that actually exists. And in subgroup analyses, regardless of the specific cause of CKD, diabetes or non-diabetes, IgA nephropathy, etc., dapagliflozin led to hard cardiorenal benefit. And so, of course, this has led the nephrologists, the kidney doctors, to say, well, it looks like SGLT2 inhibitors are actually kidney drugs that just happen to lower blood sugars. I want to take a moment to go back to the cardiovascular outcome trials, because the interesting thing about cardiovascular outcome trials is that from a kidney perspective, the patients enrolled in the CVOTs were actually at low risk. So in DAPA-CKD and Credence, of course, patients fell into the red zone of the heat map. But in Declare TIMI 58, Canvas, and EMPA-REG outcomes, from a kidney perspective, again, by albuminuria and by eGFR, patients were in the green zone of that heat map. And in fact, I'm going to pin down a little bit. Take the next slide. There we go. Declared TIMI 58. This was what the CVOT, of course, of dapagliflozin. But the fascinating thing about Declared TIMI 58 is that 60% of the patients in Declared TIMI 58 actually did not have pre-existing cardiovascular disease. They just had multiple risk factors for cardiovascular disease. So this was actually, in many ways, a primary prevention study in which many of these patients, the aim was to prevent them from having their first cardiovascular episode. The fascinating thing about Declare TIMI 58 is that, again, in secondary analysis of the study, on that hard 3-point nephrologic outcome, they found substantial benefit in patients who were on dapagliflozin. So that was a 47% relative risk reduction in dialysis, sustained drop in GFR, and renal death. I'll take the next slide. And so the implication of Declare TIMI 58 is that all of your patients with diabetes may have some degree of renal benefit from SGLT2 inhibitors, although in patients without diagnosed CKD who don't have the macroalbuminuria and who don't have a decline in their GFR, of course, the number needed to treat will be a lot higher. But when you look at subgroup analyses of Declare TIMI 58, so this is that data right now, you can see that from a renal perspective, the benefit of dapagliflozin was pretty similar, regardless of whether patients had normal albuminuria, microalbuminuria, or macroalbuminuria, regardless of their baseline eGFR status, whether they had established cardiovascular disease or multiple cardiovascular risk factors, and even in patients on ACE inhibitors or ARBs at baseline. And again, the kidney doctors are excited about this because the last time they've had a medicine that's produced this kind of benefit was back in the early thousands when the big trials of the ACEs and the ARBs actually came out. So it's been a long time from a kidney perspective. I'll take the next slide. And of course, just to show you that this isn't specific to dapagliflozin, here is the similar subgroup analysis of the nephrologic outcome from EMPA-REG outcomes, showing pretty much exactly the same thing. Okay. Now, of course, we have to stop a moment to talk about safety because the Canvas program did show a doubling of amputations in patients who were treated with canagliflozin. I'd like to point out that this risk wasn't evident in any of the other SGLT2 trials, but it did show up in the population studies. So these are data from an observational study, a cohort study, a huge cohort study published in BMJ featuring data from multiple European countries showing a doubling of amputations in patients treated with SGLT2 inhibitors. And actually the predominant SGLT2 inhibitors in Europe during this period was dapagliflozin. But I'd also like to point out that absolute risk difference. So Rose, if you could highlight that first exactly, of 1.5 in 1,000 patients, which is tiny compared to the benefit you're getting to your patients. And there are many diabetologists actually who don't think of the amputation risk as a thing. I would advise though, you may need to exercise caution if your patients have severe peripheral artery disease or active diabetic foot infections. Now, SGLT2 inhibitors are known to increase the risk of DKA over twofold, but again, this is a rare outcome, DKA, in patients with type 2 diabetes, that absolute risk difference of 0.7 in 1,000. And the key thing here is that the risk of DKA can be mitigated. You mitigate it by counseling. Take the next slide. You counsel your patients to stop the SGLT2 inhibitor in the event of a dehydrating illness. And this is a handy dandy acronym. I'm sure you're all familiar with it, but if you haven't, it's world changing. It's your handy dandy acronym promoted by Diabetes Canada, SADMANS. For the medications, you should consider telling your patients to stop or hold if they get sick for some other reason and can't eat or drink or can't keep down their fluids. And that would be their sulfonylureas, their ACE inhibitors, their diuretics, metformin, ARBs, NSAIDs, and SGLT2 inhibitors, the new addition. I think it used to be SADMAN and now it's SADMANS. So there you have it. Next slide. Now, the most common side effect of an SGLT2 inhibitor is yeast infection. This can be scary for men, but if they're prepared for it, it's not a big deal. The risk of true urinary tract infection is not actually increased by SGLT2 inhibitors. Now, I'm going to say this for completeness sake. There have been multiple cases of Fournier's gangrene in patients on SGLT2 inhibitors. And again, I'm mentioning this for completeness because I'm pretty certain there's a strong element of reporting bias here. If you take 2 patients and they both come in a hospital with Fournier's gangrene, and one of them is on an SU, and the other one is on an SGLT2 inhibitor, if you're in the States, which one of these are you going to report to the FDA's adverse event reporting system? It's probably going to be the one on the SGLT2 inhibitor, right? Fournier's gangrene is a pretty rare occurrence anyways, and diabetes alone is a risk factor for it. So overall, SGLT2 inhibitors are pretty safe, but some counseling and mitigation is required. Okay. Now let's come back to the case. Let's come back to Darryl. This 62-year-old male with type 2 diabetes, he has CKD. And yeah, there are some other things we could target here. His blood pressure could be a little better and he needs to stop smoking. But he also has a pretty decent indication for an SGLT2 inhibitor, regardless of his HbA1c. And if we treat 25 patients like him with an SGLT2 inhibitor, we'll prevent a cardiorenal endpoint. Again, either a case of dialysis or a sustained 50% decline in his GFR, or even a cardiorenal death. All right. In terms of the practicalities of getting him on an SGLT2 inhibitor, I'd like to turn it over to my colleagues for their thoughts. So the way we'll do this is a roundtable where we'll all present specific thoughts we have about this patient. And I think we'll start with Donna.
Hi. So with this fellow, I rely very heavily on the CKD pathway to guide me in treatment. And in diabetic patients, I really look at their renal impact, and I become really concerned when I start to see the glomerular filtration rate go under 60 or when there's some albumin in the urine. So that's before this fellow, right? And this fellow, I probably would have consulted a nephrologist. And it depends on the nephrologist as to what I would do. A lot of the nephrologists I have already have reviewed all the medications and told me what medications they want my patient on. And with those nephrologists, I might write a letter and say, you know, do you think this might be a good medication to consider? Would you consider an SGLT in this fellow? And sometimes I'll get a letter back saying, no, let's stay with the Ramipril or whatever he's on, you know. And I've had others that say, yes, go right ahead. Now, in other diabetic patients that have a lesser renal impact, the main hesitation I have prescribing an SGLT inhibitor is really the ability of my patient to afford it. And I have some patients that aren't on Blue Cross, they just can't afford it. Some of them have plans that can, and then the ones on Blue Cross, what a headache. I feel that the forms are making me into somewhat of a dishonest person. What I'll often do is prescribe a couple weeks of glycoside and have patients return to visit me, and I'll document all the horrible side effects they have, and also talk to them about their needle phobia. And then I will look at, filling in a form and optimizing medication. Next slide. With patients, at every appointment, I really prioritize what I want to do. When I go in the room, I call it agenda setting with the patient. I want to really focus on the big fish to fry because I don't have a lot of time. So where are my patients willing to go? With this fellow, the approach is akin to eating an elephant. So you want to eat it one spoonful at a time, and sometimes with ketchup. But of course, we're talking diabetes, so no sugar in that ketchup. We're always going to look at where our patients are willing to go and what they're ready to change. And the big thing for this guy would be the smoking. However, he may not be wanting to go there. And if not, I'm not going to waste our time. So I'll look at other things, and things in lifestyle are really big with diabetes. Diet and exercise and checking in on it, and little changes make big changes. With this fellow, I'd also consider other things, such as sleep apnea, if he has fatty inflammatory liver disease and other things. I document the discussions in my note, so I know what to go back to in future visit. And I'll use tools such as a goals page, and you'll hear all about that further down in this talk. Next slide.
Okay, I guess I do have some thoughts about prescribing SGLT2 inhibitors in patients with CKD as well. And, even as someone who keeps on top of the evidence, whenever I'm doing something I've never done before, I feel a little bit of anxiety about it. And one of the things I'm anxious about with SGLT2 inhibitors, of course, is we all know that when they first came out with their indication for diabetes, the eGFR that was allowable for that indication was between 45 and 60%. So a lot of our CKD patients would actually be excluded. And I'm sure that was partly because, as Rose pointed out in her mechanistic slide, by the time you get to GFRs that low, the blood sugar lowering impact of the SGLT2 inhibitor actually becomes quite small. But these patients still have cardiorenal benefit, and that's the new news. And Health Canada, actually, the labelings are being updated as we speak. In 2020, anyways, all of the SGLT2 inhibitors in the market in Canada actually received labeling for eGFRs down to 30 for certain specific indications. So that's reassuring. I'll take the next slide. I mean, if you do have a lot of trepidation about it, like Donna says, I mean, it's always worthwhile getting the nephrology opinion, especially if they fall into the red zone on the CKD heat map. That's when the kidney doctors like to see patients. I would like to point out, yes, you do expect a transient dip in GFR as you relieve the intraglomerular pressure with the SGLT2 inhibitor. The overall prognosis of GFR is better. There is much less GFR progressive loss in patients on SGLT2 inhibitors. And the trials actually have not shown an increase in true acute kidney injury in patients treated with SGLT2 inhibitors. In fact, we have observational data suggesting the exact opposite. This is data from a study out of Ontario looking at exactly this question. And if you look right down at the overall risk ratio at the bottom, this is the risk of AKI, and the risk ratio is actually 0.8. That's barely, but actually statistically significant in favor of a protective effect of SGLT2 inhibition. So I hope that's reassuring anyways. That's reassuring for me. There might be select patients where I still look repeat the labs and check the creatinine and electrolytes. I'd probably delay it about 4 weeks though, just to make sure I'm not caught by that earlier swing and tempted to stop the SGLT2 inhibitors given their pretty decent track record of safety. Okay.
So my thoughts on this patient. With his A1C of 7.1%, we want to look at this in his global context. And I think, this case is really focused on the fact that his CKD is really what is going to drive our prescribing changing rather than the A1C. Now, most of the patients I see have an A1C much above 7%. And so I'm trying to get them on any medication that's going to help with glucose lowering. But I think we just have to keep in mind what is the goal for this gentleman. And we say a goal of 7%, and this was largely based on the fact that our drugs gave us certain limitations of hypoglycemia. And now that we have better drugs and better approaches, I wonder where we should be really putting that A1C into context now with these better medications. And, I think Donna did a really good job of talking about that shared decision-making and starting where the patient is at. What I like to do with these patients is really relate the numbers to their functioning and relate their glucose values, specifically glucose in what I tend to do, to how they're feeling. So if they're having a lot of hyperglycemia and they're noticing that they're tired when it comes on, or they're noticing that they don't feel very well, that their energy is poor, that's where I'm able to get them to be motivated to try something new and to try something different. So I think it really is about talking about where the patient is at in terms of symptoms, how that relates to what we can measure, and get them on board with the different therapies. Now, when it comes to SGLT2 inhibition, we have that cycle of adoption. And when it comes to flozinating, I would consider myself one of the earlier adopters of flozinating, but I think, this is something where you just have to reflect on your own practice. And as you get more experience with these drugs, I think you'll feel more comfortable prescribing them for your patients. So I think that this is really up to each of us to look at this data, reflect on it, and try to adopt it into practice as much as we can. And when we look at the Diabetes Canada guidelines, they have now established that for patients with CKD, we preferentially want to use SGLT2 inhibitors to reduce that progression of nephropathy. So it's very clear in the guidelines, we should be using these drugs. And I hope this gives you more confidence to be an early adopter and to flozinate.
Hashtag flozinate.
Yay. So I'm going to move the discussion now from individual patient to assessing a panel of patients. We know that data is important. It helps us become aware of blind spots. I call it data readiness. So we need data to help improve the quality of care we provide. Next slide. You may or may not know of the Canadian Primary Care Sentinel Surveillance Network. It's quite a big mouthful. If you want to say it shorter, you call it SIPSN, just like sipping tea. It's Canada's first multi-disease electronic medical record. A number of us practice-based research network directors and family physicians all across Canada were very frustrated that we couldn't get funding for what we saw as our community laboratory. We need infrastructure funding really to support our community laboratories. And we saw electronic medical records as a potential for great data and an excellent source for chronic disease surveillance, research, and practice improvement. As family physicians, we all need good data. Most of the data that informs us and informs our policymakers comes from data sets that are not really about us, billing data, hospital data. We need our own data to better inform us in our practices. In 2008, we were fortunate enough to get funding through the Public Health Agency of Canada to test the feasibility of extracting and cleaning data from, we did it, I think, about 13 different electronic medical records for the purpose of surveillance, research, and quality improvement. And we're still going today. Today, there are practice-based research networks all across Canada. Saskatchewan is coming up to par. They were a bit later in getting their EMRs underway. And we have two networks in Alberta, the Northern Alberta Primary Care Research Network and the Southern Alberta Primary Care Research Network. Now, the Northern Alberta Primary Care Research, we call it NAPCRN for short. I'm the research director, and we recruit practices north of Red Deer. And Neil Drummond is the director of SAPCRN, Southern Alberta, and they recruit south of Red Deer, and we sometimes have both in Red Deer. Again, we clean and structure their data, the physicians participating in NAPCRN and SAPCRN. And in Alberta, we're extracting data from MedAccess, Wolf, Tellen, HealthQuest, Accuro, and Practice Solutions. It's a real rich data set. And it's a nice way for family docs to contribute to meaningful primary care research projects and research done by their colleagues that can inform us about our discipline and about our practices. The practicing physicians and primary care providers also benefit from getting data resources, such as individual data reports, and I'll show you some examples of that, and practice improvement tools. SIPSN has developed validated case definitions. Now, this is really important, and sometimes people don't recognize it. A case definition is an ability to identify who in your EMR data has a chronic condition. Now, you might think, oh, I can just search my problem list. Well, that's not true. We found that what you put in your problem list is often poorly coded, and you're probably missing a lot of patients with a chronic disease. So for disease registries, if you want to identify patients with diabetes, COPD, dementia, and do practice level assessments, it doesn't work too well when you have data that doesn't inform you. Next slide. So to effectively use our electronic medical records to do quality improvement, we need to improve the data in our electronic medical record. And I took a screenshot of our data presentation tool of, this is actually my practice, I'm the provider, and it shows my data in a dark purple, and then my sites data, and then all the data in NAPCRN. And what this shows you is how I've coded diabetes in my profile. And this was a quality improvement activity I did so that I could identify all my patients with diabetes. And in that way, I can assess them. So you can imagine, if you're in NAPCRN and you're only identifying 67% in your profile, you're missing a large number, if you're trying to evaluate how you're doing, or if you wanted to call them in for an intervention. Diabetes, I found in the data, is better identified than other conditions. Hypertension isn't as good, and I've taken a screenshot of that because that's also important with diabetic patients. And you can see that in the network, about only half of the patients are correctly identified as having hypertension, in their electronic medical record. So coding and meaningful use of an electronic medical record can really improve our data. And to improve the use of our medical record, resources sometimes outside of the medical record, such as the data we provide, can help you identify and properly code and clean that data. Next slide. Now, this slide is an example of a report. This is actually my report. And we send this to all the sentinels contributing data to the network. This is just a very brief overview of diabetes, of some of the things we could look at. And it illustrates how the individual physician, that would be me in green, compares to their site and then compares to the entire network. And you can't, when you look at these reports, you are the only one that knows how good that is for you. I can tell you when I was practicing in more disadvantaged practices, the results would look very different than this. So you're the one that looks at these reports and decides, is this good for you? With my report, I've been working a number of years on the diabetic panel and with patients, and particularly trying to identify patients who are a bit overweight. And you can see the capture of weight in my data is quite high. So I've got my staff capturing weight. And as soon as I get people a bit overweight, I'm actually picking up diabetes early, and in some cases with lifestyle reversing things. So that's where things for my practice might look a little different. You know, so it depends on what your practice is as to how you would use these reports and do quality improvement. Next slide. This is an example of Med Access and the ability to use a goals page. In Med Access, we've set up diabetic goals. And the square box on the left-hand side, you can pick what diabetic goals you want your patient to have. And you can also adjust and tailor that target to the individual patient. So I would check off and then tailor it and then set it. And what happens then is when the patient comes in for appointments, on the right side, you will see the goals. And the ones in red are the ones that are outstanding. And often what happens when in that day before patients come in, I'll often look at who's coming in and I'll prepare you know, labs and things and that to save time so that I can update goals when I'm seeing patients. And some of these, again, I prioritize because, again, you have only a brief visit and it's the ones that you really think are important that you want to focus on. Next slide. This is an example of a TELUS Dash that's in my EMR and Med Access. And this is a nice, very simple tool. The box on the left, you can see the blue pie. And if I click on that, it'll give me the list of all my diabetic patients. And I can go into their charts and just see how things are going. The circle on the right, the different graphs, they have hemoglobin A1C that's overdue. And that's fairly common in my practice because, again, some patients are really well controlled, so I'm not measuring them as often. But it also shows you glances as to hemoglobin A1C targets. And you can click on any one of those pies and it'll bring up a list of those patients. Next slide. This is a wonderful slide that we all worked on. I think, Rose, you did the heavy elephant eating on this slide, and I think she used a lot of ketchup. This is a slide that illustrates data coming out of the network and how prescribing looks in Northern Alberta. And you can see these are patients that have chronic kidney disease at different levels. And when you look at the flozinates, you can see we're not really flozinating very good, right? We could be better flozinators. Now, there are many reasons for this, and some of it may be knowledge, and I think, and some of it may be, a lot of people aren't early adopters. But it could be other things. And I think, I know for me, a big factor was the forms and the cost, which were huge for me. And then, the other thing is, I am hesitant when I have patients on insulin as well, to start them on these, because I'm nervous about prescribing on insulin. So there are many reasons that we may be seeing this, but I think this is a wonderful example of how data from the network can be used by researchers and family physicians contributing to that research, and that can enlighten us and help us change practice. Next slide.
So that brings us to the take-home messages from this chat. So it's clear from the evidence tonight and from the guidelines that if a patient has type 2 diabetes and chronic kidney disease, we are encouraging you to flozinate and become a flozinator. We want to start renal protection early, and beware that when we do start flozins, we will anticipate a potential drop in GFR, and give it more than 2 weeks. Check 1 month after you've started the medication to let them settle out, as long as you don't have any other medical concerns. Don't forget about SAD/MANS. We need to, I was just listening actually to a podcast today about acute kidney injury being more prominent in people with diabetes. And so it's really, really essential that we do that medication counseling and get our pharmacy team members to reiterate the medication counseling on the nephrotoxic drugs to stop when fluid depleted. And lastly, don't forget about the CKD pathway for further information and resources for those with CKD. Oops. So thank you very much for listening, and we'll now open it to questions and comments. And don't forget to tune in next week for our diabetes and CBD talk at the same time next Wednesday.
Thank you so much to everyone here on the panel. I think that was definitely informative for many of us. Just to remind everyone, the Q&A portion of the webinar, that's how we're handling questions and answers. So if you can actually plug your questions into the Q&A portion, that would be great. We're just actually going to go through a few of them. I know Darren had actually answered one of those. Darren, I'm just going to draw attention to it just in case people hadn't read through your answer. So someone had asked, can you start SGLT2 inhibitors in patients with chronic kidney disease but who are not diabetic?
Right. So my answer is, based on the results of DAPA-CKD, the answer is yes. And in fact, the kidney doctors are very excited about it, and they'll be rolling out quality metrics in their own SCN shortly, looking at patients who should be on SGLT2 inhibitors. But you're going to have practical difficulties right now because the listing does not exist yet with Health Canada. It's not actually indicated yet. It is FDA just approved it in the States for dapagliflozin specifically based on DAPA-CKD, and the manufacturer AstraZeneca is actually seeking that indication from Health Canada right now. So there's the indication, but without the indication, you won't have drug funding for it. So Blue Cross is going to lag. They always do. You're just not going to have funding for patients who don't have diabetes to be on these medicines. So in theory, the answer is yes. I think the kidney doctors are actually getting behind it, but it'll be a little more until practically you're able.
Thank you, Darren. I'm going to draw attention to a question, maybe Rose. You'd just been talking about lab follow-up after you start an SGLT2 inhibitor, and someone's asked, what labs do you recommend after starting an SGLT2 inhibitor, and when is it best to do them?
So you don't have to worry about potassium. You don't have to worry about these other things. I would just do a GFR, just do a creatinine, 1 month, at 1 month.
All right, thank you for that. And I think someone was asking about what the patient's BMI was, and I think this is a great one for Donna. Will SGLT2 inhibitors also help his blood pressure, and would one actually be able to stop the glycoside? And how aggressive should we be as GPs?
I don't know that it would help the blood pressure. Others might know that, but it definitely get people off the other medications with it. And I find it works really well at addressing their diet as well. I don't know, it seems that with these drugs, I can help them improve their diet as well.
Darren, do you want to talk about blood pressure, or did you want me to take that question?
Either of us could actually. Rose, why don't you go ahead?
Yeah, so these drugs, Flozins on average will drop the systolic blood pressure, about 5 points systolic and a couple points diastolic. So people do have to be wary if they are already well controlled on other blood pressure lowering medications. They may need adjustments to their other blood pressure medications when they're starting Flozins.
Yeah, so the other thing about Flozins to recognize is that they typically produce anywhere from 100 to 400 mils of extra diuresis a day. And so maintaining hydration is important. And if they're already on diuretics, you might consider replacing the diuretic actually, if their blood pressure is well controlled. But in answer to the second part of that question, will one may be able to stop the glycoside? How aggressive should we be? Most of us doing diabetes work actually do as much as we can to get people off of insulin and glycosides if we can pull it off. And this fellow with his A1C of 7.1%, if we can sneak him under 7.0% with that combination of SGLT2 inhibitors and GLP-1 receptor agonists, which have a fair bit of weight loss attached to them too, then yeah, let's get rid of that glycoside, right? Because all that does is increase his risk of hypoglycemia and make his belly bigger. And we know that patients on glycoside tend to have progressive decline in like their diabetes control as time goes on anyways. And that's been well demonstrated in the UK PDS studies back in the 90s.
And the diuresis effect does tend to taper off. So people will have that diuresis effect initially for, days to weeks, but that does taper off.
Okay. Darren, let's throw this one back to you. Is an SGLT2 inhibitor safe in elderly people who have diabetes and chronic kidney disease?
Right. So yeah, it depends. This is the patient where I would follow a little more closely and where I would probably definitely measure that 4-week creatinine. The key thing about the elderly patients is that they're very vulnerable to overdiuresis, and you wouldn't want them to be dizzy, lightheaded, have a fall. So that's the one where you might exercise a little bit more caution. You might adjust their medications to make sure they don't dry out too much. It probably is safe, but I would, in my practice, be just a little more cautious, warn them a little bit more, make sure the family knows what side effects to watch out for, and remeasure that creatinine in 4 weeks if they are on the border near eGFR 30. That's how I feel about it.
Yeah, and I will add, in some patients that I'm nervous about, I will start them at half dose. I'll get them to crack the tablet in half and try half for a few days before going to full dose to see if they tolerate it.
I thought there was a type 1 question that I thought was fascinating. I wonder if Rose would be interested in us addressing.
Sure.
Yeah, that was the one I was going to ask next. Yeah, so it asks, can we start using SGLT2 inhibitors in patients with type 1 diabetes and chronic kidney disease for renal and cardiac protection?
Right. So the official stance from Health Canada has not approved the Flozins for type 1 diabetes. However, I believe dapagliflozin is approved in Europe for type 1. And I imagine that this is a matter of time. So I have a very large type 1 practice, and I discuss the off-label nature of using SGLT2 inhibitors in type 1. And the big danger is the ketosis, the DKA. So this becomes a bit more tricky and a bit more based on your comfort with insulin and your supports around reducing insulin. So this all has to be personalized based on their existing glycemic management and their hypoglycemia awareness and their knowledge of what to do during sick days. So I would absolutely not advise using SGLT2 inhibitors in patients who do not have good basic education and who cannot, do sick day management with their insulin. But if somebody is very well educated, they have a continuous glucose monitor, they're followed carefully by your team, it's something that you can consider, but must make them aware that it is off-label and that, all those caveats need to be addressed.
Thank you so much, Rose. I'll throw it out to actually anyone, but is it appropriate to start an SGLT2 inhibitor in a newly diagnosed diabetic with proteinuria without even trying metformin?
That's a good question. Certainly, I might consider both, actually.
The very practical answer is if you're looking for Blue Cross funding, technically you need 6 months of metformin therapy to achieve it.
Yeah.
So let's just leave it at that.
So you put them on metformin, and then you get them to get 2 weeks of the other glycoside.
Samples for 6 months.
And hear about their side effects, and nobody likes needles, so then you get it.
Yeah, so I think once again, it does point to the practicality of availability. Now, I think in the best case scenario, when we compare the data from clinical trials and even observational data around metformin benefit compared to what we now have with SGLT2 inhibitors, one could easily argue that SGLT2 inhibitors have more robust, better data to support their use. So I think that, we'll see the tides shifting. We're already seeing it in some of the other guidelines where SGLT2 inhibitors and GLP-1 agonists are being the preferred therapies off the bat. But Diabetes Canada has not made that recommendation quite yet.
Thank you, everyone. I just want to say thanks to everyone for attending. We can maybe stay on a little bit longer in case people want to ask more questions or have some of the other questions answered. And but please, to our attendees, take a few minutes to provide us with feedback by using the link that's provided in the chat. So not the Q&A, but the chat. And there's also a QR code that's running around on the slides here as well. So you can use either or. And if you're interested in participating with co-creation projects, please provide your info at the link that's provided there as well. And there's a QR code as well in the slides. I don't know if there are any of our panelists wanted to pick any other of the questions to answer, but I thought we got some really good ones done already. So it's great to see the participation from everyone today. It's really exciting.
I'm curious because I hear different answers from different colleagues. What do folks think? There's 2 questions about amputation risk, actually. And I thought that's Roshan, do you see the questions? Do you want to give them a readout?
Yeah, so I actually had one of them written down. So just in case it didn't actually show up. So one person asked about risk of amputation. Would you avoid SGLT2 inhibitors after an amputation for, I'm assuming, a diabetic foot injury? How about if if you already had a bilateral sort of knee amputation, or would you suggest avoiding? Orthopedics typically recommends no SGLT2 inhibitors if patient has needed bilateral knee amputation.
I think this is difficult. I have colleagues who would not hesitate, and the reason on their end could be that a lot of folks don't actually believe that the effect seen in the Canvas program is real. The placebo group in Canvas actually had a remarkably low rate of amputations. So it's unclear whether it was a chance that the placebo group had such a low rate, making it look like the Canna group had a higher rate of amputations. And certainly the signal didn't show up in the other trials. By the time they get to amputations, a lot of these patients have very difficult to control blood sugars, and we're getting pretty desperate for something to get them down. But on the flip side, if they've already, especially if they still have limb to preserve, if the amputation is actually partial, toes or ankles, and they still have limb to preserve, but they have severe peripheral artery disease, then you might feel a bit dicey about it, right? So I can understand there is a fair bit of tension here. I don't think I have the perfect answer. I think if they have peripheral artery disease, they might have already had cardiovascular events. And from a heart perspective and from a CKD perspective, you got reasons to get them on the SGLT2 inhibitor. Yeah. My personal preference would actually be to trial it, but I know that's a variable, and so I'm very curious as to hear what Donna and Rose think. Actually,
I think it's a really good question, and what I would do is just gather as much information from colleagues such as yourself and my patient, and try to help them decide a bit. My tendency would be, if cardiovascular is a real big concern, we may be doing them more benefit with that, right? But I think our patients are fairly smart, or a lot of them are, and maybe they're more concerned about their limb, so I need to know where they're at too, right?
Yeah, it's very difficult because it's hard to tease out the cause of amputation being the underlying metabolic derangement versus is this the drug. So I would be looking at their case history, and I would be trying to tease out, do I think that this is actually due to, or sorry, they haven't been on an SGLT2 inhibitor. So I would look at their metabolic status. And if their metabolic status is very bad and they're not doing well on insulin and we've tried everything else, then I would offer it to them with a caveat that if they have worsening of their peripheral vascular disease, then maybe we need to stop it. I would also be maybe preferentially looking at, have we tried GLP-1 in this person? Are they candidate? Looking at the other options. But certainly, the ortho, if our orthopedic colleagues are putting a kibosh on this, I think that's actually pretty harsh and probably needs to be relooked at with other, medicine colleagues to help make that decision. Because I don't think it's fair to, avoid a very powerful class of medications in these patients who likely would benefit.
Yeah, I mean, these patients often do have peripheral artery disease, so they would have been included in trials like EMPEROR-Reg Outcomes, for example, which showed cardiovascular benefit. Like they saved heart attacks, right, by being on these agents. So that's a bit tricky, but that's a really good question. And actually, now that you've mentioned it, I'm going to have to pick the brain of the next orthopodist I see to see how much this is a thing among the orthopedic surgeons to contraindicate SGLT2 inhibitors.
Maybe
right.
A future co-creation project. Hey, Rose?
Sounds like a great idea, Roshan. Sounds like a great idea.
We do have one question that's shown up twice, I believe, by the same individual. So I thought I would at least put it out there. Should we be reducing, or how much should we be reducing insulin when we're actually starting an SGLT2 inhibitor?
So that really depends on where they're starting from. So if their glycemic control is, if their A1C is high, then there's no need to reduce insulin unless they're having hypoglycemia. So I think, this really is a personalized approach depending on their baseline medication doses, their baseline rates of hypoglycemia, and what else is happening. So I don't have a one size fits all. But generally speaking, if, for this person, who has our case, who has an A1C of 7.1%, I would argue there's still room to go. So if he was on insulin, I would just add it on and counsel about the increased risk of hypoglycemia and to be prepared when they're starting the medication and getting used to it. I don't know, do others have any thoughts on that?
Sometimes self-monitoring of blood glucose can help too. Yeah, if they're keeping track of their own blood sugars, that can be very helpful. I actually rope people into. I rope a lot of my patients into joining me on new medicines and engaging with care by saying I'll do my darndest to get them off of insulin, and they love that. Right. So, and then they'll measure their blood sugars because they want to see if this new stuff gets them off of insulin. They'll cut down their insulin doses. It's a big motivator, actually.
I think we have an answer sort of in the Q&A about how I think on service, one of the attendees actually touched base with orthopedics about this. So maybe there is a co-creation in the future with our colleagues in surgery. I'm going to actually, one question just because of a personal interest for me, because it popped up and it doesn't necessarily have to do with the topic, but Donna, could you touch upon how the data set may be different from the NAPCRN data or the SIPSN data when compared to the HQCA data?
HQCA is other data repositories, so that's billing data, it's hospital data, it's not point of care, it's not from our electronic medical records, so it's a different data set. So they're making inferences from these data sets about what we do, and we're looking at what we do to determine. I think there's tremendous power in, having said that, I think there's tremendous power in linking data sets. And we do have a number of projects where we are linking our EMR data with, for example, we're looking at diabetes data and other, potential data linking, because they tell us different things. But the data sets that don't come from our EMR can be a bit misleading, right? Because it's not what we're doing. It's not what we're entering. It's being inferred from other data repositories. I don't know how to explain it any better.
Oh, I think that's a perfect explanation. We're going to squeeze in one last question. I have a patient who developed DKA on SGLT2 inhibitors. Would it be worthwhile trying her on it again, or should she never go on another SGLT2 inhibitor? Rose.
Okay. Yeah. So I think the question is, was there a trigger to the DKA? Did the DKA come out of nowhere, or was it anticipated because of illness or major stress? Was she running a marathon? What was the circumstance around it? Because if it was unexplained and out of the blue, then we're more hesitant to give her another trial. I think the other question is she on insulin? Was she on insulin? Is that in the question?
No.
I don't believe so. It says I have a patient who developed DKA on SGLT2 inhibitors. I don't know if there's another one.
Oh, right. So the question is, because if she developed DKA and she is not on insulin, then this may be pointing out that she may be insulinopenic. She may actually require insulin. So that's one question. If she is on insulin, maybe her insulin dose is insufficient. So she may be imbalanced in her doses and may require more insulin to avoid the ketoacidosis. So those are some considerations. Because what we know about the DKA that can occur is it usually doesn't come out of the blue. There's usually an antecedent cause that is a stressor on the system. And that's where that sick day counseling is really important.
Mhm.
Well, thank you to our panelists, and thank you for all the great questions from our attendees. Again, I'll refer you to the slides for the QR codes, as well as the links to both the feedback as well as the co-creation opportunities. And it's also in the chat, although you have to go a little bit further up just because we do have some lovely questions in the chat as well. Thank you all for attending. We really appreciate it.
Thank you. Good
And
night.
thank you to our panelists.
Hope to see you next week.